Okay, how is everybody? My name's Joseph Moirano. I'm an MS2 at Zucker School of Medicine, and I'm gonna be working with Sal today. We're gonna be doing the abdominal and pelvic structure. And the abdominal is probably gonna be the first like 2/3 or so, and then we're gonna turn it over to Sal and he'll be doing the rest with the pelvic structure. So I hope you guys enjoy today. If you guys have any questions, feel free to put it in the chat or anything. I'm going to try to look at it as much as possible. And then we also have a couple other MS2s that'll help out with any questions or anything as well.
Hey guys.
How's it going?
Great. Thank you all for still contributing to this. It's fantastic. I think everyone loves it. One of my favorite sessions, without a doubt. Just wanted I didn't mean to interrupt, but I wanted to remind everyone that at 10, Dr. Langer is doing Chairman's Corner. And he's got a very special guest today who we all helped get to more Instagram followers than she could have ever imagined, or I guess Twitter followers. But so great job, everyone. Stick around. It's going to be a great morning. Carry on.
Cool. Perfect. Thank you, Randy. Okay. So good. We're going to get started right away. Okay. So yeah, today we're going to be doing abdominal and pelvic structure. And just these are kind of the learning objectives and things we want to try to accomplish today. So that's going to be understanding the anatomy and relationships of the abdominal and pelvic cavities and the structures within them. And then we're going to try to integrate surface anatomy, physical findings, and imaging to get kind of an overall clinical approach of what's going on in the abdomen and within the pelvis. So what we're going to be doing is kind of just going through some of the anatomy, and then like everyone else has been doing in the past few lectures, we'll be going through some cases as well, just to kind of bring it all together. Okay, so abdominal structure. So first thing that we're going to kind of start off with is the surface anatomy of the abdomen, and we're going to kind of work from the outside in. And I just like this first slide just because it kind of keeps that reminder of always trying to understand what the actual words mean that we're going over when we're looking at all these things. And I think people like Ben talked about this a lot in week 1, that it makes it a lot easier when you're trying to learn all these concepts if you actually understand what these words mean. And a lot of the words come from like Latin and other languages from back in the day when it was all created in Europe. So just to go over some of these kind of surface landmarks, we have the linea alba, linea semilunaris, and the transverse intersections. And if you think of just the names and what they mean, you know that linea means line, and then alba, that alb means white. So it's kind of that white line that's going down the middle of the abdomen. And it's kind of the same idea with linea semilunaris. So semilunaris is half moon, and you could see that this line on the outer region of the abdomen kind of looks like a half moon curving over. And it's important to remember for these that these aren't actually on the outside of the body. They're structures that are more internal, and they're going to be deep to the skin. But these are structures that you're kind of able to see if they're very defined in certain people. And this is actually what kind of makes a six-pack, if an individual has a six-pack. It's because these transverse intersections and this linea alba and the linea semilunaris is very prominent. That's because there's just so much less fat in that abdominal region, and there's so much more muscle. So that muscle is kind of coming to the surface and showing itself. So that's kind of, these are all concepts that we're going to look at a little bit more in the next few slides when we move a little bit more internally, but it's just good recognition to be able to understand what these mean. And what is this in relation to the fascia? Yeah, so the skin would have to be completely retracted back in order to be able to see these actual fascial layers. So like you're saying, the linea alba, linea semilunaris are fascia. And pretty much what fascia is, it's kind of like the ending of a muscle. And when that muscle ends, it kind of like teeters off. So it starts out long and then comes kind of together. And that fascia is just this connective tissue that's pretty much made of collagen. And the reason why it's called like linea alba is because that connective tissue and that collagen actually shows up really white when you look at it grossly. And by grossly just means looking at it like with the human eye. And that's why they call it alba, because it's really white and it has that distinct feature. And we're going to be saying that when we go over the actual layers and muscles of the abdominal wall in the next few slides. But to start off, one of the most important things that you'll have to know, and this is in any type of medicine that you're in, whether you're doing PA school, medical school, nursing school, anything, are the different ways to kind of tell the different regions of the abdomen. And there's going to be 2 different main ways that physicians will kind of classify the different regions of the abdomen, and it's going to be into quadrants and then 9 regions. And I've seen both of them be used, and that's with working in emergency departments and other like outpatient facilities for a few years. And both of these are used a lot, and it's things that you definitely need to have kind of down pat in order to be able to understand what physicians and other medical professionals are talking about. And the main point of this is just to be able to recognize what different organs are within these different regions. So when we're looking at the quadrants, there's going to be 4 main quadrants, and it's going to be right upper, right lower, and left lower. And then when you're looking at the regions of the abdomen, it's going to be a little bit more specific, dividing into smaller than the actual quadrants are. So if you look at something like the epigastric region, you could think that the stomach is essentially in this region right here, and stomach means gastric, and then epi means above. So this region is going to be a little bit above the stomach. And same idea with kind of like the hypochondriac regions for the right and left hypochondriac. I think as Marianne, I was talking about it last week, that chondro means cartilage. So pretty much these 2 regions, hypochondriac is going to be a little bit below the cartilage. So you can see that these 2 regions are a little bit below the ribs. And it's going to be the same type of idea for all the other things as well, with how these are named. And a lot of times you could even see physicians kind of crossing over between both of these terminologies when talking about a patient. So it's important to know them all, because you could have a patient that's coming in with something like appendicitis, and then the physician will say that the patient had pain that started in the umbilical region, and then that pain ended up migrating to the right lower quadrant. So kind of just in that little history right there, you saw that the physician can use both the 9 regions of the abdomen terminology and then also the quadrant terminology. So it's really important just to be able to make sure that you have both of those ideas down. Then like I was saying before, we're going to be going over the main anatomy. So you want to understand what different organs are within these different quadrants, because then you could kind of begin to deduce what the possible etiology of a patient's pain may be based on where that pain is located within the abdomen. So let's say, for instance, somebody's having pain in their epigastric region, you could kind of deduce that that pain may end up being something that's related to the stomach or the pancreas or something that's kind of located in the upper abdomen, because that's where those organs are located within the human body. Okay, so next what we're going to be talking about are the muscles of the abdomen. And there's pretty much 3 main muscles that you want to remember. And that's going to be the external oblique, internal oblique, and then the transversus abdominis. And they're going to go in that exact order from essentially the outside to the inside, so from superficial to deep. And then there's going to be a couple layers that are also more superficial to those muscles as well. And that's going to be the skin and then the different fascial layers. So the different fascial layers are going to be Camper's fascia and Scarpa's fascia, and those are going to be just below the skin. And then deep to those layers are then going to be this first one here, which is going to be the external oblique, then the internal oblique, then the transversus abdominis. And then all the way on the inside here, there's going to be something that's called the transversalis fascia, which is not the fascia from the transverse abdominis, but it's its own fascial layer kind of in itself. And I think it's really good to be able to look at the CT scan that we have here. So just to orient yourselves, again, I know we went over this a little bit in the last few weeks, but this is going to be the right side. This is going to be the left side of the patient. This is going to be the posterior aspect of the patient, and this is going to be the anterior aspect of the patient. Hopefully you guys should be able to see my cursor with where I'm pointing to. But the important thing, you can kind of orient yourself with this because you know that the vertebral column is going to be more posterior. And then once you do that, you're able to really see a lot of these structures, and they're pretty well defined on this CT image in particular. You could see these 3 different muscle layers here. So you can see that this most outer one here is going to be the external. This one here is going to be the internal. And then this one here is going to be the transversus abdominis. And then one other key point to remember with these different muscle layers of the abdomen, pretty similar to how you guys probably learned when you were learning about pulmonary structure by Brendan Morgan in week 2, is that they're going to have different orientations of the fibers. So the external oblique is pretty much going to be going from the outside of your abdomen down towards like your mid. Then the internal oblique is going to be at essentially like a 90-degree angle to that and is going to be going up towards your sternum. And then transversus abdominis, just like the name kind of makes it seem like it would be, is just going to be going transverse across. And then the last thing to be conscious of is that there's a rectus abdominis as well. And that's going to be running kind of from the top of your body downwards. And that's going to be what we talked about a little bit in that first slide, where you have these tendinous intersections, which is kind of the fascial layer of the rectus abdominis. And then you also have the linea alba and the linea linea semilunaris, which we talked about as well before, which this is all going to be that fascial covering. And remember that that fascia is this connective tissue, and that connective tissue is mostly made of things like collagen, and that's going to show up white when you see it in like gross anatomy. So when you actually see it in person, if you're doing surgery or something like that. Okay, so kind of just expand on this and make sure that we have a little bit of an understanding of this. We're going to look at something called the rectus sheath and then the arcuate line. So the arcuate line is something that's really important because this right here is the arcuate line, and that kind of detonates the region where the fascial layers of these muscles are going to start to change, whether they are going pretty much anterior or posterior to the rectus abdominis muscle. So that's going to be pretty much this region right here. So everything above the arcuate line is going to have this orientation like this here. So that's going to go with everything above. And pretty much what's going on here is that we're going to have the internal oblique muscles fascia going both above and below the rectus sheath. And then the external oblique fascia is going to be going fully above the rectus sheath, or fully above the rectus abdominis. And then the transversus abdominis fascia is going to be going below the rectus abdominis. And then it's important to remember that we also have the transversalis fascia as well. And no matter what, that's always going to end up being going underneath the rectus abdominis muscle. And then the big change that happens when you go underneath the arcuate line here is now all of these fascial layers from all of these muscles are actually going to be going above the rectus abdominis. So there's going to be a change in how these fascial layers are oriented. So now it's going to be the fascial layer from the external oblique, the internal oblique, and the transverse abdominis are all going to be going above the rectus abdominis, and then your transversalis fascia is still going to be going below that muscle. And that's just some important anatomy because that's something that will be important to surgeons when they're working on the abdomen, because you want to be able to kind of see the differences between those fascial layers based on where you are within the abdomen. Okay, so we just have a first case here. And let me just erase this stuff real quick. Okay, so the first case is saying that there's two patients that are in the OR. One is to have an open cholecystectomy through a kosher incision, which is this over here. And then the other patients have a C-section via a fan seal incision, which is this one down here. And as we can see, this one here is going to be below the umbilicus. And pretty much the question is just how do the layers of the abdominal wall that the two surgeons must traverse differ for these two procedures. And you guys could just write some ideas in the chat or anything if you have any ideas. And I saw some say, yeah, so the arcuate line is located pretty much right below the umbilicus. Okay, great. Yeah, so if you look at this, now let's go through a little bit of the case discussion. And it's kind of just exactly what we were talking about before. Yeah, above the arcuate line, there are more layers to transverse than the fascial incisions. Yeah, so pretty much the idea is that when we're above the arcuate line, all the fascial layer of the internal oblique is essentially going to be separating. So we see here that this is the internal oblique and this is its fascial layer. And this will be above the arcuate line. So that would be for the kosher incision. And for that one, you're going to see that this fascial layer is going both above and below. And then the transversus abdominis fascial layer is going to be going all below. And that's just something that's really important. That's a difference between this one down here that would be below the arcuate line for the fan and seal incision. Because if you have an OBGYN that's doing a surgery and is trying to traverse these layers, they want to make sure that they see all of these fascial layers above the rectus abdominis to make sure that they're within the right region of the abdomen. So it's kind of good ways to be able to understand different landmarks and make sure that you're in the correct places. Okay, so next thing that we're going to talk about are the different organs of the abdomen. And one cool thing about the abdomen is that it's obviously not just one organ in itself, like we've done in the past few weeks, but there's so many different organs that are within, and they also have so many different functions. So most of the organs within the abdomen are going to be part of the digestive system. So if we're looking at the digestive system, that's here to the left. And just to do a quick overview, we have the mouth here, that's going into the esophagus, which is next going to the stomach. Then from the stomach, we're going to go into the small intestines. And the small intestines is going to have 3 different parts to it. And that's going to be the duodenum as the first part, then the jejunum, and then the ileum. And then we're going to go from there into the large intestines. And that's going to be this region all here. And pretty much there's going to be kind of 3 main portions of the large intestines that you guys want to know. And that's going to be the ascending portion. So that means that it's going upwards, then transverse portion. And transverse is going to be going like axially across the body. And then the descending portion, which is going to be going back down. And then you also have your sigmoid colon, which is this little part right here, and then your rectum as well. But then it's also important to remember know that there's so many other portions or so many other organs within the abdomen as well that have other functions. So you have organs like the liver and the gallbladder and the pancreas, which do have functions eating and digesting, but also have their other functions as well. And then you have things like the renal and the urinary system, where you're going to have the kidneys and the adrenal glands and the ureters, and they're going to be sitting a little bit posterior to a lot of these other organs within the abdomen, but they're all located within the same cavity, essentially. So whenever you have, let's say, patients coming in with abdominal pain, you have to be able to look at all of these different organ systems to try to deduce what could possibly be causing their pain. Okay, so if we're looking at the different divisions of the abdomen, a good way to kind of split this up is to split it up into its blood supply. So we're going to classify the abdomen by pretty much 3 different ways, and it's going to be by the foregut, the midgut, and the hindgut. And the way that we're going to do this is based on the blood supply, and that's from the celiac trunk to the foregut, the superior mesenteric artery to the midgut, and then the inferior mesenteric artery to the hindgut. And the important thing for this is that all this blood supply was pretty much based on embryological development of these different regions, which is something that we're not going to go into right now today, that development. But it's important to remember each of the different organs that are classified within the foregut, midgut, and hindgut, because that'll also have implications when you're learning other things about like nervous innervation, stuff like that as well, which we won't get into today. But it's really important for the anatomy and where these are located. So we're just going to run through each of these different divisions of the abdomen, looking at the foregut, the midgut, and the hindgut, and just their different blood supplies that impact them each. So like I was saying before, the foregut's going to be mainly supplied by the celiac trunk, which is right here around T12. The midgut is going to be supplied by the superior mesenteric artery, which is just a little bit below that celiac trunk, and that lies at about L1. And then the inferior mesenteric artery is slightly below the superior, and that's going to be around L3. And another common point to kind of make yourself aware of is the bifurcation of the abdominal aorta, and that's going to be happening around L4. And a good way to remember that is that you can remember it's bifurcation. So you could remember that's going to be L4 that's separating. So if the main thing to be able to get out of all these different things about the midgut, foregut, midgut, and hindgut before we really get into them is that the foregut is going to be from the celiac trunk, midgut's going to be from the superior mesenteric artery, and then the hindgut is going to be from the inferior mesenteric artery. And then as you can see, there's also a ton of other branches that are going to be coming off the abdominal aorta here. But we're not going to really go into many of these other ones now, but it's just to kind of make you aware that there are so many other branches coming off of the aorta. So first thing that we're going to start off here is talking a little bit about the foregut. And like I was saying before, the main branch for the foregut is going to be the celiac trunk. But then essentially what's going to happen is that celiac trunk is going to end up dividing into smaller and smaller arteries that are going to supply each of the different regions within the foregut. So the main structures that are supplied by the foregut or by the celiac trunk, which are parts of the foregut, are going to be the lower esophagus, the stomach, proximal duodenum, liver, gallbladder, pancreas, and spleen. So there's 3 main branches that are coming off this celiac trunk here, and 2 of them are going to move to the left side of the body if you're the patient, and then 1 of them is going to be moving to the right side of the body if you're the patient. The 2 moving to the left side are going to be the left gastric artery and the splenic artery, and the 1 moving to the right side is going to be the common hepatic artery. Another thing that's really important to remember with these things is that this orientation of these vessels is not always going to be the exact same thing for every single patient. So there can be times where a patient may have their left gastric artery coming off a lot later from the splenic artery, or their left gastric artery may be coming off directly at the trunk of the celiac trunk. So it's just something to remember that, yeah, we have this kind of classification for how normal anatomy is and the most common, but that these things can change from person to person. So if you're working as a surgeon and you have individual's body open there and you're looking at this anatomy, you have to be able to identify what these things are, even if they're in a slightly different location, because it can change from patient to patient. And that could have a lot of impact on what specific kind of like procedures and techniques you'll be doing based on where these things lie. Okay, so the first thing that we're going to be looking at here is the stomach and the spleen and the blood supply to those two organs. So like I was saying before, all these things are going to be coming off the celiac trunk, and the main three arteries off the celiac trunk should be the splenic artery, left gastric, and then the common hepatic. So if we're looking at the stomach, there's going to be kind of four main arteries that are supplying the stomach. One is going to be the left gastric, which was coming right off that celiac trunk. One is going to be the right gastric, which is coming off the common hepatic artery. And these are both going to be supplying the lesser curvature of the stomach. So this curvature of the stomach that is smaller is called the lesser curvature. And this part that is wider is going to be called the greater curvature. So you have the left gastric and right gastric arteries are going to be supplying the lesser curvature. And then you have the gastromental or the gastroepiploic arteries are going to be supplying the greater curvature of the stomach. And the left gastromental is going to be coming directly off the splenic artery. And then the right gastromental is going to be coming off the gastroduodenal artery, which is a branch off the common hepatic artery. So it could definitely get a little confusing when looking at these because there's so many different arteries and so many different branches coming from so many different places. But if you just draw it out a few times and try to make sense of it as much as you can, then it becomes a lot easier. And obviously this image here on the top left doesn't have all these organs in their actual correct orientations within the body, but it's just more so to be able to show you kind of the actual arterial supply to these. And a lot of times the placement of these different arteries has a lot of tie into actual like pathology and etiologies as well. So we see that we have the splenic artery running here behind the stomach. So if there's any like pathologies or anything within the stomach, especially on that posterior portion of the stomach, then you could have something happen where you could have kind of compression of the splenic artery in some way, and there could be some like pathologies that can happen with that. I see a question, what do you say supplies a greater curvature? Okay, yeah, so greater curvature is this right here, and that's going to be supplied by these two arteries. So it's going to be left gastromental and right gastromental, which are the same thing. It's the same exact meaning as gastroepiploic. And what ends up actually happening here is that these two arteries come together and create something called an anastomosis. And what an anastomosis is that they kind of share the same blood supply, so that if one of these arteries gets cut off, because let's say we have some type of like embolism or something that comes and shuts off part of that artery and there's a loss of blood supply, now that other artery can kind of compensate a little bit and help to supply it so that this greater curvature doesn't move all of there or doesn't lose all of that blood. Okay, so to continue, we're going to be looking at a couple of different organs of the foregut here. Over here, we're going to be looking at the pancreas and then our proximal duodenum, because those are still parts of the foregut. And the pancreas is going to be receiving most of its blood supply from the pancreatico-duodenal arteries. An important thing to remember about the pancreas actually is that it's going to be receiving blood supply from both the foregut and the midgut, and that it's going to be receiving from the superior pancreatico-duodenal, which is off the gastroduodenal artery, which is off the celiac, and it's also going to be receiving stuff from the superior mesenteric artery, which has the inferior pancreatico-duodenal artery coming off it. And another clinical tie-in here that we'll get into a little bit later is that the positioning of the superior mesenteric artery within the abdomen is actually also really important, because we see right here that the superior mesenteric artery is coming over part of the duodenum. And there's some pathologies where this can actually end up compressing on part of the duodenum and can cause problems with food being able to move through this region. What was it called when two arteries share the same blood supply? Yeah, it's called an anastomosis. And that's going to be a really common topic pretty much within all medicine when you're looking at anatomy. And we see the same thing actually happening right here. The anterior and posterior superior pancreatico-duodenal arteries and the inferior pancreatico-duodenal arteries also create an anastomosis as well, when kind of supplying the head of the pancreas here. So that's something that you're going to see a really lot. So it's definitely good to be able to understand that concept and understand the idea that if blood supply is cut off from one of those, the other one's going to try to supply it as much as possible so that there's not any problems. Okay, so then if we continue with that, we're going to be looking at the gallbladder here, and the gallbladder is going to be receiving blood supply off of the cystic artery, and the cystic artery is a branch off the hepatic artery proper. And then the other branch from that is also the hepatic arteries, which are going to be supplying the liver. So if we look down here at the right, we're going to be looking at the blood supply to the liver, and the blood supply to the liver is really, really important because it's going to be receiving blood from pretty much two different regions, or two different, let's say, vessels. And it's going to be receiving from both those hepatic arteries that we were talking about, so a left and right hepatic artery, but also this other structure that's called the portal vein. And we're going to get a little bit into the portal vein when we talk about the venous drainage from the abdomen, but it's really important to remember that the portal vein is going to be draining pretty much all of the blood that was from the abdomen. And instead of going directly back to the heart first to be oxygenated, this blood is going to first pass through the liver. And by that blood first passing through the liver, that's really important because that's how your liver is able to be the pretty much detoxification organ of the body. So you have all this blood that's coming from your gut from things that you just ingested. And now all that stuff is going up through this portal vein, going into your liver in order to be detoxified so that all these really bad toxins aren't going to be going systemically into your body. So that's how really your liver here is so important. Okay, perfect. So we're going to keep going from there. And the next thing that we're going to be talking about here is the midgut. So the main thing with the midgut is it's going to be supplied by the superior mesenteric artery. And there's a couple different branches off the superior mesenteric artery, and that's going to be the inferior pancreaticoduodenal artery. And that's kind of what we talked about before when we were looking at the pancreas on the last slide. And it's important to remember that that inferior pancreaticoduodenal artery is going to be making an anastomosis with the superior pancreaticoduodenal artery as well. And then you'll have the jejunal arteries here as well, ileocolic, right colic, and middle colic. And like we were talking before about those different anastomoses that can be created between different arteries, that's essentially what happens with the entire colon here. So as you see that there's all these little branches that are kind of coming together and creating this little essentially like ring of fire around the colon, that's all pretty much small anastomoses that are trying to help supply the entire colon if there's any problems with blood supply to any region. And then like I was saying before with the superior mesenteric artery, and if we go back here, you can see that superior mesenteric artery is moving over the duodenum. And that's an important kind of clinical tie-in because if there's less fat within this region, you can actually get a syndrome called SMA syndrome. And what SMA syndrome is that superior mesenteric artery is compressing down on the duodenum, and now food's not able to pass through the duodenum into the jejunum and the ileum and then the rest of the large intestines. And that could cause a lot of different problems like nausea and vomiting and all stuff like that. And just to make sure that we have the point across, the structures that are going to be supplied by the superior mesenteric artery, which is part of the midgut, is going to be from the distal duodenum to the proximal 2/3 of the transverse colon. So that's going to be the distal duodenum, the jejunum, the ileum, and then we're going to have the ascending colon and 2/3 of this transverse colon. And then to finish off the arterial blood supply, the last thing is going to be the hindgut. And the hindgut is going to be the inferior mesenteric artery. So that's where the hindgut is going to receive all of its arterial blood supply from. And the structure of supply there is going to be from the distal third of the transverse colon. So that's going to be starting pretty much right here to the upper portion of the rectum, which is going to be right around here. So that's going to go from the rest of the transverse colon here, then the descending colon here, and then the sigmoid artery here, and the superior portion of the rectum. So the major branches that are coming from there all make sense because it's named for the regions that they're going to be supplying, just like where all the other arteries. So you have the left colic artery is going to be doing the descending portion of the colon. The sigmoidal artery is going to be doing the sigmoid colon. And then the superior rectal artery is going to be doing the upper portion of the rectum. And I see a question, what causes the duodenum to be compressed against superior mesenteric artery? So yeah, so someone said something like anorexia. Yeah, so a patient that is anorexic and has a lot less fat within this region can get something like SMA syndrome, because now there's so much less fat to kind of insulate and hold that superior mesenteric artery away from the duodenum, that now it's pretty much compressing down, and is going to cause food to not be able to travel through that region. And then another important thing to kind of show a clinical tie-in with here as well is that we were talking about that idea of anastomoses and how they're really helpful. But one problem, or one portion of the colon where this becomes a problem, is this left colic flexure, which is also called the left splenic flexure. And why this becomes a problem here is that the inferior mesenteric artery is supplying blood to this portion, and then the superior mesenteric artery is as well from these ending branches of the middle colic artery. And what happens is that there's pretty much two distal branches from each of these arteries supplying this left colic flexure. So if a patient is really hypotensive in that they lost a lot of blood, so let's say a patient got in a really bad car crash and lost a ton of their blood, this is one of the first portions of the body that will actually go ischemic. And by ischemia, that means just lack of blood flow or perfusion to that organ. And that's because this portion right here is especially kind of susceptible to that, because these are distal portions of both the superior mesenteric artery and the inferior mesenteric artery. And it just makes it kind of a bad portion for when you have a little amount of blood within your body. Okay, so the last thing that we're going to talk about, we went through all of the arterial supply essentially to all of the organs within the abdomen. So now we're going to look a little bit just at the venous drainage. And the venous drainage is pretty much based on that idea that I was saying before about this portal system. So the main idea of the portal system is that you're going to have blood coming back through veins from all these abdominal organs. And instead of going directly to the inferior vena cava and straight to the heart to be oxygenated, they're passing through the liver first. And like I was saying before, the importance of that is so these different kind of toxins and things within that blood that were received from the outside world in your food are going to go through the liver in order to kind of be detoxified and to make sure that they're not going to be too harmful to the body. So what you're going to have here is you're having the inferior mesenteric vein, and the naming is pretty much same idea as before, where it's going to be inferior mesenteric, superior mesenteric, and splenic vein. They're all going to be coming together to create this portal vein. So you have the portal vein here. The portal vein is going to go and is going to kind of disperse all this blood into the liver. And then all that blood is going to come together into what we call the hepatic veins. And this is something that really does become very important when you're actually looking at this stuff clinically and like later in your life when you're actually practicing. Even yesterday, I was watching some procedures done by interventional radiologists, and they were doing a procedure called TIPS, which is essentially when you connect this portal vein to this hepatic vein, because there's pretty much the liver is too cirrhotic and all these miniature veins have issues with them. So what's going to end up happening is that you're pretty much doing x-rays and ultrasound the entire time throughout this throughout the procedure, and having knowledge of this anatomy and knowing where these actual veins are located and what different blood supplies are coming to them is very, very important. So this is something that I was going over with these physicians literally yesterday, looking at the anatomy of this portal venous system, because it's really, really just so important to be able to know it when you're actually working clinically. Okay, so the procedure's name, it's called TIPS. So it's TIPS, and it stands for Transjugular Intrahepatic Portosystemic Shunt. And it's pretty much like, in more so layman's terms, just a stent that is going from the portal vein to the hepatic veins to pretty much bypass the liver, is the idea. Okay, so just for this quick case where you have a 35-year-old patient comes to ED complaining of pain that started in the middle of the abdomen, but is now mainly present in the right lower portion, and that CT scan is shown. And then a 50-year-old patient with a history of alcohol abuse presents with upper abdominal pain after a few nights of drinking, and that scan is shown below. So first thing, just to orient ourselves, these two CT scans are taken in different planes. So does anyone know what two planes these CT scans are taken in? Okay, yeah, we got a lot of answers, and it seems like most of them are right. So we have the first one is going to be coronal plane. So just like I think Ben was teaching in week one, coronal plane, imagine like the queen with her crown and you're facing her from the front. And you could see that this image looks like you're kind of cutting that patient in half from the front. Yeah, good job, everyone. Yeah, Ben, you taught them well. And then the second one is that transverse plane. That's the one that we've been showing you guys a lot. And just to kind of orient, this is going to be the right side of the patient. This would be the left side of the patient. This would be the anterior aspect, and this would be the posterior aspect. So I guess just to look at this a little bit more, based on the history that I gave for these two patients, what do you guys think would be the different kind of etiologies or the issues that these patients are having? Or just some different things that could be that they could be having based on where that pain is kind of described. Okay, yeah. So for this right one, I'm getting a lot of good answers, and there's a lot of different answers too, which is good. So I saw a couple people saying liver, which is definitely a good thought. But if we think a little bit more about the specific kind of patient excerpt that we had here, we see that the pain started in the middle of the abdomen, which would be about here, and is now present mainly in the right lower portion of the abdomen. So if pain is actually going to the right lower portion, that would be a little bit different than where the liver would be. You'd think of a problem with the liver would present with more right upper quadrant pain. So this would probably be something like a lot of you guys are saying now with the appendix. And like I was saying before, appendicitis is something that classically will present with pain starting in the middle of your abdomen and then moving to this right lower quadrant, which is right here. And this is actually the appendix that's right here, this little black hole with this kind of graying around it. And this is not stuff that we have to kind of go over or know now. You could see that there's a little like shadowing over this appendix, and that's pretty much called periappendiceal fat stranding. And that's something that's pretty common to be able to see with patients with appendicitis. So it's just important to be able to remember that idea that wherever this pain is described for this patient, a lot of times correlates where the actual location of the pathology is within the abdomen. So always important to be able to listen to your patient and kind of get where that location actually is, because that'll help you out so much when you're trying to come to that diagnosis. And how about this second one, the 50-year-old patient with the history of alcohol abuse with upper abdominal pain? Okay, so I'm seeing a lot of different ones. And I'm seeing a lot of liver. There was a couple of people that I saw that got the correct answer here, which for this specific image is actually going to be pancreatitis. But everyone that was saying liver, that's also a great idea as well. And just based on the patient history, liver is definitely an appropriate answer, because liver is going to be in the upper portion of the abdomen and will present with pain kind of across those upper portions. But based on the CT scan we have here, which we don't obviously know how to completely read CTs yet, but this is going to be the pancreas in this outline that I'm doing with my cursor. And as you can see, this pancreas is a little bit inflamed and also has these little kind of nodules, if you guys can make it out. And usually the pancreas should be pretty flat and smooth. And you shouldn't see these little nodules and this little graying around the pancreas. So this is something that's kind of in line with a diagnosis of something like acute pancreatitis. But what everyone was saying with the idea of a patient with a history of alcohol abuse and everything having problems with the liver, that is 100% correct as well. And a patient like this could probably also have problems with that as well. Okay, so we have a couple more minutes. So we're going to go through this last portion quick. And this is just the idea, case 2 discussion. We're just talking about being able to recognize the different problems that present within these different regions of the abdomen. So like I was saying before, right upper quadrant would be things that affect the gallbladder, the liver, duodenum, some parts of the pancreas, some parts of the colon that are coming up there. The right lower quadrant is going to be things like the appendix that we saw in the last case, portions of the ascending colon. For female, it could be problems with like the ovaries or the uterine tubes. And then left upper quadrant can be problems with the spleen, because the spleen's located right here. The left kidney kind of lies in this region, the jejunum and the proximal ileum. So a couple different things based on those. It's just important to kind of have these ideas in your mind when patients are telling you where their pain is located. Okay, so for the last portion that we're going to do here for the last 5 minutes or so is we're going to be talking about the peritoneum. And this is pretty much the same idea that you guys got from your lectures in week 2 on the pulmonary structure and then week 3 on cardiac structure as well, is that the peritoneum is going to be pretty much analogous to the pleura that you learned and the pericardium that you learned. So pretty much the ideas for both of those were that you have kind of this ball and then you have organs pushing into it, and it kind of makes that ball involute on itself. And that's what this image is showing right here. So you could think that this organ in a different way, if we were looking at it as the heart, this would be the heart, and then this would be the pericardial cavity. And it's the same idea here for the abdomen as well. And it was the same idea for the lungs. And just for the abdomen, it's now called the peritoneum instead of the pericardium or pleura like for the lungs. And it's important to remember here that the way that all these organs are going to receive their blood supply is that it's going to be going through this portion within here that is pretty much open to the rest of the kind of like contents of the body. And just like the same thing with the lungs and with the heart as well, you're going to have a parietal peritoneum and a visceral peritoneum. And so it's important to remember the visceral peritoneum is going to be lining the actual surface of the organs, while the parietal peritoneum is going to be lining the abdominal cavity. So those are just words you really want to make sure that you kind of understand the meaning of, because like you guys have seen now, it's come up in 3 consecutive lectures. So it's important to be able to just understand what these things are. So kind of going off of that, we're going to be looking at 2 different terms that are named intraperitoneal and retroperitoneal. And essentially what this is that intraperitoneal organs are covered on all sides with visceral peritoneum. So that would be something if we were looking at the heart. The heart would be an intraperitoneal organ if it were within the abdominal cavity, because that heart is covered on all sides. And then retroperitoneal is going to be organs covered with peritoneum only on pretty much their anterior surface. So it could be a pretty hard concept to understand. And it's a lot easier when being able to actually view the abdomen grossly and actually see it during a dissection. But I think that this picture right here does it some justice in being able to actually see and understand intraperitoneal versus retroperitoneal, because you could see that these organs in here, this would all be the small intestines that's here, are completely covered by this peritoneum. So the peritoneum is kind of going around and it's completely covering all of that. And then you have other organs here like the kidneys, which you could see are only being covered by a portion of this layer. And that's what's going to make the difference between the kidney here being retroperitoneal versus these other organs like portions of the small intestines, which are going to be intraperitoneal. And there's just a really good mnemonic for when you guys possibly have to memorize this in the future for what are going to be the retroperitoneal versus intraperitoneal organs. And that's going to be the mnemonic SAD pucker. So I have them all listed here, so I'm not going to read them out to you guys for time's sake, but it's just a good way to remember the idea of intraperitoneal versus retroperitoneal. And the main takeaway that you want to get from here is that intraperitoneal is covered on all sides with that visceral peritoneum, while retroperitoneal is going to be only covered on the anterior surface. Okay, so just to finish it off here, we're going to be talking a little bit about the lesser and greater sacs within the abdomen. And these pretty much go in line with what we learned about for the last slide when we learned about the difference between intraperitoneal and retroperitoneal and the idea of the parietal and the visceral peritoneum. So like we were learning before, the parietal peritoneum is going to be the one that's lining the abdominal cavity. So if I'm able to annotate here. So pretty much your parietal is going to be all around here. It's going to be actually lining the abdominal cavity like this. It's going to be draping over these pelvic organs, and then it's going to be going to the back here as well. And then anything that's in actual direct contact with organs within the body is going to be the visceral portion of that peritoneum. So right here, we'd start the visceral portion, and this is going to go like this. It's going to wrap around the stomach because it's going around organs. It's going to be going around here and here and here. And then what's also going to happen is you're going to have a visceral peritoneum on this other side as well, also coming together. And what ends up happening here is now we have these double layers of this visceral peritoneum coming together. And these things get some specific names. So the specific name for this double layer right here is going to be the lesser omentum. And then the specific name for this double layer of peritoneum here is going to be called the greater omentum. And these are definitely kind of difficult concepts to be able to visualize in your head just by looking at this sagittal plane here. So it's definitely good to, if you're having kind of difficulty with these concepts, maybe just look up a YouTube video when they could actually show you the different planes of it, because it really helps a lot. Because I had difficulty understanding this as well at first. But the main idea then with this is that the way that these form and these peritoneals kind of enclose on each other is going to create two different sacs within the abdomen. And those sacs are going to be the lesser sac, which is here in this blue, and then the greater sac, which is going to be in this green and in this red. And one important idea here is that there is one connection between these lesser and greater sacs, and that's this thing, that's the epiploic foramen. And what's going to happen is that that allows some contents from here being able to go into the greater sac. And just to do a quick recap of that, I'm going to do the last case that we have here, just so that Sal has enough time to be able to do his portion as well. Okay, so this case here is going to be after 10 hours, a few hours after eating, a patient arrives to the ED with 10 out of 10 abdominal pain. And the patient reports that he was rolling around in bed because of the pain. An X-ray reveals some free air in the abdomen, and the patient undergoes a laparotomy, which is pretty much just an exploratory surgery within the abdomen to see what's going on. During the procedure, stomach contents are noted surrounding the small intestines and greater omentum, but there's no ulcers in the anterior wall of the stomach. So pretty much the question here is, how did the contents end up where they did? And if anyone has any ideas here, they can write them in the chat, and then we'll go through it quick. Okay, so hole in the peritoneum, hole in duodenum. Okay, so there's one answer that I saw that's really great here, causing contents to leak from the smaller sac to the greater sac. Yep, through the epiploic foramen. Yeah, so that's going to be the exact idea here. So what we're seeing here is in this right picture, I kind of made a drawing of it, and I put this little lightning bolt where this kind of ulcer was and where contents were able to leak out. You could see that if contents are able to leak out into this lesser sac, and then if this patient is kind of rolling and moving around so much, now you could have these contents from this lesser sac go through this epiploic foramen, because remember we said the epiploic foramen is the one place where these contents can move. And now once they're able to move through the lesser sac, through the epiploic foramen into the greater sac, now they could go around and go anywhere within this greater sac. And like we saw in the case vignette, the patient ended up having all those contents around their small intestines because the small intestines are here within the greater sac. So yeah, the posterior wall of the stomach is where that kind of rupture was within the abdominal wall. Because if it was anterior portion of the stomach, then it would be going directly into the greater sac. Okay, great. So that's everything that I believe I have. So then Sal will take over pelvic structure for the last portion of this. Sorry, Sal, I took a little bit of your time, but I hope you're able to get through enough.
No worries. Yeah. So we're just going to go through pelvic structure in like the next 10 minutes, and we're going to move a little quick, but if you have any questions, all the other students helping out with teaching this course will be happy to answer questions in the chat. So we're going to start first with the hips and pelvis. Joe, you can switch the slide for me. Great. So with the hips and pelvis, there's a couple really important bony structures that you need to keep in mind, because this is sort of what holds everything in the pelvis together. So if you look on the top, you can see the ilium. There's like sort of a wing-like shape. And towards the top area, you're going to see an iliac crest. That iliac crest is an important landmark because it sort of distinguishes at that L4, L5 territory where the aorta will bifurcate. You can also see the sacrum as well as the sacroiliac joint. There's also the pubic symphysis right in the middle, the ischium on the bottom, and the ischial spine in the middle. Additionally, another couple things you should keep in mind are the fact that the coccyx is at the most inferior portion, and there's also the anterior superior iliac spine as well as the anterior inferior iliac spine. And then the pelvis is sort of cocked forward a little bit. You can see that the anterior superior iliac spine is in line with the pubic symphysis, and it sort of has an anterior tilt to it. And the pelvic inlet is there as well. A difference between males and females with the pelvic anatomy in terms of the bony structure is that males tend to have a circular pelvic inlet and females have a larger pelvic inlet that's often more heart-shaped, and this allows females to be able to accommodate for childbirth. So we can move to the next slide. On this slide here, we're going to look at some of the muscles that hold everything together. It's sort of called the pelvic floor and the pelvic diaphragm. So the pelvic diaphragm is made up of two groups of muscles, the coccygeus muscles and the levator ani. The levator ani itself is actually made up of three separate muscles called the iliococcygeus muscle, the pubococcygeus muscles, and the puborectalis muscle. The pelvic diaphragm moves anteriorly and inferiorly, and it courses towards the midline, and the coccygeus sort of attaches on the posterior portion. It has a sort of triangular shape, as you can see. Both the levator ani and the coccygeus muscle both attach to the ischial spine on the lower front anterior part of the pelvis. And then on the right here, you can see an inferior view looking from inferior to superior. You can see that there's the perineum there as well. The perineum is sort of the floor, and the pelvic diaphragm is sort of like the ceiling. And there's just a bunch of organs and viscera that hang out in there. You can also see there's, in the perineum, you can see the urethral opening as well. And so we can move to the next slide. So there's a few differences in the pelvic viscera between men and women. Namely, there's ovaries, there's a uterus and ovaries in the women, and men do not have that. The peritoneum sort of drapes over all the pelvic viscera, as you can see. And you can sort of see that in women, there's two different sort of folds or pouches that occur because of that. There's the rectouterine fold as well as the vesicular uterine fold. And that sort of is an area where fluid, if there's ascites or internal bleeding in the peritoneum, that's where it will collect because of gravity. In men, there's only one. It's a rectovesicular pouch. And so fluid can also collect there. And so there's also going to be a difference in where fluid can collect if it's intraperitoneal versus like extraperitoneal bleeding. So at the very tip of the rectum where there's no peritoneum, you can get bleeding that does not occur in those pouches, or fluid collection not in those pouches. And in women as well, there's a couple ligaments that form that help to carry some of the uterine tubes. And yes, that's basically just what some of the viscera that lie in the pelvic cavity exist. We can move to the next slide. So another really important system that occurs within the pelvis is the urinary system, and it sort of starts with the kidneys, where you have right and left ureter that drain into the bladder. And from there's going to be some anatomical differences between males and females. You can see with females, there's a shorter urethra, and it enters through a shorter distance into the urethral orifice. With men, there's the bladder that drains into the urethra, and there's 4 different parts of the urethra here, and it's a much longer urethra. It's about 20 centimeters long. You can see there's a preprostatic part, a prostatic part, a membranous part, and a spongy part. And then it exits through and out the urethra. And on the right, you can sort of see how everything is situated within the pelvis between the bones and the muscles that we just went through. So we can move to the next slide, where we're going to talk about some cases. The case is a patient has arrived in the ER with 10 out of 10 pain in the right flank region. The patient mentions that they have been experiencing this pain for a few hours and that the pain is not relieved by adjusting their body position. The patient reports nausea, vomiting, difficulty urinating, and blood in their urine. So what are a few diagnoses that should be on your differential? Great. So you guys got it, kidney stone. So we can move to the next slide and we can kind of go into this a little bit further. So if we're going to just orient ourselves, superior is towards the top, inferior is towards the bottom, and then right and left are flipped. So there was right-sided flank pain. So this is going to be a right kidney stone. And there's two different ways that this can sort of manifest within the body where the obstruction can occur specifically. So there's something called a uretero-vesical junction obstruction, as well as a uretero-pelvic junction obstruction. And you can see on the left, this is a uretero-vesical junction obstruction, or a UVJ. And you can tell because there's a larger amount of contrast more superiorly, and the obstruction is a little bit more distal. So you can kind of see like the whole kidney lighting up here, as well as some of the ureter lighting up here. On the right, you can see this is a UPJ obstruction. And you can tell there's the obstruction occurs more proximally towards the kidney. And you can see that the kidney is lighting up here because there's a lot of fluid collection. And at the bottom, you can also see that there's contrast in the bladder as well. And so we can move to the next slide for our last case. So the last case is a patient has arrived at his doctor's office for a checkup. He hasn't seen his primary care physician for several years. When the physician asked what brought him in today, the patient was embarrassed, but explained to the doctor that he's having a really hard time urinating. He mentioned that he feels the urge to urinate and that he must strain very hard to pass urine. He also goes on to describe how his urine flow is often discontinuous and that he often feels that he hasn't completely voided all of his urine. Lastly, he reports very dark urine on occasion. So where would you localize this issue if you have to say? Okay, great. Somebody already, prostate, BPH, and enlarged prostate. Great, that's exactly where we're going. We can go to the next slide and talk about this a little further. So you can see here on the top left, this is a very full bladder. This often occurs when there's an enlarged prostate or BPH. BPH stands for benign prostatic hyperplasia. This is when there's a growth of some of the cells and tissue in the prostate. And as we mentioned before, there's a prostatic part of the urethra that the urethra has to pass through the prostate in order to go towards the external orifice. And so if that prostate gets enlarged, it can sort of squeeze out of urethra and not allow urine to pass through, which is why we have a very full bladder on the top left ultrasound image. And then on the bottom left, you can see this relationship I was just explaining between all the organs. There's a bladder, the prostate, and the urethra that passes through it. But on the right, bottom right here, you can see how the enlarged prostate can kind of sort of constrict this urethra and not allow urine to pass through, which is why we're seeing some of the symptoms of urinary hesitancy, straining when urinating, sensations of incomplete voidance, and the hematuria, or the blood in the urine, can occur if there's an excess strain. The vessels in that area are very, very small and delicate, and so they're very prone to rupturing and bursting, which can cause blood to leak out into the urine. And on the top right is just a sort of colorful description of what we just went through and how the prostate can constrict the urethra and cause issues urinating, as well as a lot of feelings of uncomfort and pain. And a hormone imbalance, it could be too much estrogen or too much testosterone, can cause BPH and cause a lot of unpleasant symptoms for many, many older gentlemen. And with that, that is the rest of our presentation. Thank you guys so much for attending. And we're looking forward to teaching you guys next week about the musculoskeletal system. And please, if you have any questions, I know we rushed through the end a little bit here, please feel free to reach out to any one of the other students that are helping with this course. Thanks again.
Thanks, Salim. I spoke to a few of the interns personally, and I think I asked them what were some of their favorite courses, and they really love these anatomic. I think you're speaking to the level that they enjoy, and you've done a great job. I caught the end of that. It was really terrific, and teaching differential diagnosis, and it's really terrific, really great job. And you can thank all the medical students for me, because I think that the amount of effort that goes into doing this doesn't go unnoticed. So thanks for taking this over and doing such a great job.
Thank you.
Yeah, definitely. Thank you guys so much. Thanks for having us and letting us do this.
We'll keep doing it.